All right, we left off in section 5C, having finished talking about the cervical spine for the vertebral anatomy for the axial and appendicular skeleton for chapter 8. And now we're talking about thoracic vertebrae. There are 12 total thoracic vertebrae, each articulating with the ribs. And they have heart-shaped bodies, is one description for them. And of course, we talked about the superior view looking a little bit more like a giraffe, but that's technically true too. The body is heart-shaped. The costal facets or facets or demifacets are on the lateral side of the body and on the sides of the transverse processes. The head of the rib articulates with the costal facet or the demifacet, and the tubercle of the rib articulates with the costal facets on the transverse processes, and T11 and T12 lack transverse costal facets. So taking a closer look here, our thoracic vertebra, we see our costal facet and our spinous process here. Look at this superior view here, and superior articular facet and the costal facet. And we also see more of a lateral type view. We have the costal facet here, the superior articular facet, our costal facet, our spinous process protruding the posterior there, and the body of the vertebra and the costal demifacet. And of course, that being the thoracic vertebrae here. And medium size are typically not as low, they're larger than cervical, not as large as the lumbar spine. The lumbar vertebrae are the largest vertebrae. They have a thicker overall oval body, They have neither the transverse foramina nor costal facets. They bear most of the weight of the body. And so a larger body of the vertebra there. The superior articular facet, the spinous process, the transverse process, looking at it from the superior view, from lateral view. A transverse process here. There's the body of the vertebra, the superior articular process, and the spinous process. The sacrum is an anteriorly curved triangular bone. It forms the posterior wall of the pelvic cavity. The apex is a narrow pointed portion of the bone projecting inferiorly, and the base is a broad superior surface. There's 5 fused vertebrae there. They're completely fused by the age of 20 to 30, somewhere in there. The transverse ridges, there's horizontal lines of fusion remaining. They articulate with L5 superiorly, and it's via a pair of superior articular processes. The sacral canal is a continuation of the vertebral canal, and it continues through the sacrum on the posterior side. It terminates in the inferior opening of the sacral. It's called the sacral hiatus. On either side, bony projections are termed the sacral cornua. And the promontory is the anterior superior edge of the first sacral vertebra, and it bulges anteriorly into the pelvic cavity. The anterior and the posterior sacral foramina permit the passage of nerves to pelvic organs and gluteals. The median sacral crest has a dorsal ridge formed by the fusion of spinous processes. The ala is on each surface, lateral surface of the sacrum, and the auricular surface is a site of articulation with the ossicoxa of the coccyx, of the pelvic girdle, and it forms a strong sacroiliac joint, a side joint. The coccyx is a fusion of the 4 coccygeal vertebra. It begins about age 25. The attachment site for several ligaments and muscles here, and the coccygeal cornua is a prominent laminae of the first coccygeal vertebrae, and elderly may ultimately fuse with the sacrum, which is a vertebra, first of the vertebrae. So taking a look here, seeing our sacrum here, S1, S2, 3, 4, and 5, as you descend downward, the ala is here. This is the base overall here, a promontory here, promontory process. The anterior sacral foramina openings there, the transverse ridges, right? And then we have the apex here, the base here where the coccyx meets it, where we have CO1, CO2, CO3, CO4. And more from a posterior view, there's a sacral canal and superior articular facet, the median sacral crest going through here. Again, the posterior now sacral foramina, the auricular surface laterally here, the sacral cornu, sacral hiatus through here, coccygeal cornu, and the coccyx. From a clinical view, the coccyx or a tailbone injury, it's prone to bruising or fracture. Of course, landing there, very commonly people love falling backward, falling on their buttocks, falling on their butt, falling on their glutes, right? Sitting abruptly, didn't happen as often, but can happen that way. Hit during contact sports, happens too. Typically a hit than a fall is the most common. Cycling frequently, being sitting in that position there and causing some injury there by how you sit. How you sit in general can play a lot of role with the vertebrae as a whole, from top to bottom, cervical all the way through the coccyx, especially during growing years, but really at any time. Enough time is spent. Time affects a lot of things. Time in certain positions over a lengthy period of time in the position, and lengthy repeated positions. Severe pain, coccydynia is also more of a severe case here. It's slow to heal, which makes sense, right? You're talking about a fused bone. It's going to be slow to heal when you have damage there. Treatment, rest, ice, non-steroidal anti-inflammatory drugs. Being it's a non-mobile area in general, it's going to be tender. When you get a bone bruise or bruising in a bone area in general, that could be pain there for quite a few weeks. And you have to be very gentle and careful with such challenges. Herniated discs. The nucleus pulposus is protruding into or through the annulus fibrosus. You can get a herniated disc to the anterior or the posterior. Typically speaking, if you're having someone in a spinal flexion type position, you're rounded forward, the discs will herniate to the posterior. Likewise, someone who spends a lot of time in more extended positions is going to have herniated disc more to the anterior. It produces a bulging of the disc contents into the vertebral canal, none of which is good. It pinches the spinal cord or the nerves, give you some serious pain. Cervical and the lumbar discs are most commonly injured. Cervical and lumbar. Thoracic is less common, mostly because it's more mobile. Lumbar takes the brunt of all the weight above it, and it's a little more mobile, so the mobile areas are more prone to having injuries in many cases. Cervical, a lot happens there. It's the most mobile area of the spine, and not surprisingly, a lot of stress gets stored up there too, and a lot of motions. That shoulder girdle plays a big role, or pectoral girdle plays a big role with have an effect on the cervical spine as well. With the cervical herniated discs, there's neck pain, and the pain can go down the upper limb, all depending upon where that pain is in your spine. We'll talk about that nervous system in more depth on how that plays a role. Lumbar herniated discs, there's low back pain and pain down the entire lower limb, like a sciatic pain when you have a herniated disc possibility. And there's all sorts of levels of time frame for healing, because it depends upon how much of a protrusion or herniation there is, how long the herniation's been present, depending upon someone's overall spinal health as a whole. All those things play a role, let alone age and activity level, so many things. Herniated discs for treatment as a wait and see, kind of seeing how it goes potentially, from the standpoint that when you're messing with your spine, you probably don't want to go in there right away, and this is true of any surgery. If you can heal it with activity or with better postural positions or better positions of your body and repeated efforts in that regard, slowing everything down, not going fast, lowering all the loads, all those things, not doing no load, all dependent upon the issue. Likewise, you don't have no speed or no motion. Yeah, motion heals, but it has to be the right motion, has to be in the right range of motion, has to be the right speed, the right loads, the right frequency, all those things. That said, NSAIDs, non-steroidal anti-inflammatory drugs, certainly play a role, because as any good pain specialist will tell you, you can't heal if you're still in pain. So getting you out of pain and try to deal with your problem can also help. A lot of people tend to avoid NSAIDs, and this is by no means I'm not a doctor, but it's certainly very common from the standpoint of research-wise. People to avoid taking them sometimes because they're afraid of that people who are wanting to feel the pain to know what's going on. True, but also it's hard to heal if you're always in pain. Surgery, discectomy is one option, where the portion of the disc is removed. You should really, like all surgeries, you want them to be last resorts, but sometimes you don't have a choice. Discectomy, which is a vertebrae and the muscles are incised before removing portions of the disc. So what did you learn? Which vertebrae are located in the small back, and how many of these vertebrae are there? Where the secondary occurs, when do they appear, what's their general function? Compare the locations and function of the transverse foramina, intervertebral foramina, and the vertebral foramen, and how do the atlas and axis differ from other cervical vertebrae? For section 8.6, I think it's a short enough section, we'll go ahead and cover it here. Bones of the thoracic cage. You should be able to identify the three main components of the sternum and their features. Describe the features found on all the ribs, and differentiate between the true ribs and the false ribs. So, thoracic cage. It's the bony framework for the chest, right? Consists of the thoracic vertebrae posteriorly, the ribs laterally, and the sternum anteriorly. There's a protective enclosure around thoracic organs, and it's the attachment sites for many muscles. They provide attachment sites for many muscles. The sternum is the breastbone. It's a flat bone forming the anterior midline of the thoracic wall. The manubrium is the widest and most, I almost said wildest, the widest, those wild manubriums, the widest and most superior portion of the sternum. Two clavicular notches are present there. They articulate the sternum with the left and the right clavicles. Okay? And the suprasternal notch is the shallow superior indentation between the clavicular notches. Costal notches are the articulations for the first ribs and the costal cartilages. The sternum body is the longest part of the sternum. The costal cartilages are from the ribs 2 to 7 are attached here, second to the 7th ribs. It articulates with a manubrium at the sternal angle. The costal cartilage of the second ribs attach here at this sternal angle. It's an important landmark for palpation and counting of the ribs. The xiphoid process at the tip of the sternum, the most inferior tip there, doesn't ossify until age 40. Oftentimes you'll hear someone talking about potential for someone giving CPR, there being a break of the xiphoid process there at the sternum because it's potentially fragile. But then again, you're trying to save someone's life in CPR. That said, that's a whole different thing, right? Here, that's too big. Let's keep back where it was. Our thoracic cage here, our manubrium here, our suprasternal notch right here, clavicular notch there, costal notch, this upper layer of ribs here, right? Sternal angle, body, the sternum, costal notch or notches there, costal notches, a xiphoid process here. These are our true ribs, 1 through 7, okay, 12 on each side, right? The floating ribs, 11 to 12, are 11 to 12 there, and the false ribs are 8 to 12. Costal cartilage, of course, is present here. A lot of times people complain of pain in that rib area, either from impact or from motion, can potentially sometimes play a role with costal cartilage pain and strain in those areas. The sternal clinical view of a sternal foramen, it's present in the midline of 4 to 10% of adults. So less than 10% of adults typically have it. The left and the right ossification centers to fuse completely, and it may be misidentify as a bullet wound, assuming someone would be shot. That's what it looks like when looking at it. The ribs. They're elongated, curved, flattened bones. They originate on the thoracic vertebrae. They end in the interior wall of the thorax. There are 12 pairs. The true ribs, 1 through 7. They connect individually to the sternum by the cartilaginous extensions. They're termed the costal cartilages, and the smallest true rib is first. False ribs are 8 through 12. Costal cartilages are not attached directly to the sternum. The costal cartilage of ribs 8 through 10 is where you're having fused costal cartilage of rib 7, and it's indirectly attached to the sternum. And ribs 11 to 12 are without a connection to the sternum. They're the floating ribs. The vertebral end of the rib articulates the vertebral column at the head. It's divided into the superior and the inferior articular facets. They articulate with the facets or the demifacets on the thoracic bodies. They're divided by the interarticular crest. The neck of the ribs lies between the head and the tubercle. And the tubercle of the rib is the articular facet for the transverse process of the thoracic vertebrae. It's also where you have the angle of the rib is the site where the tubular shaft begins to curve. The costal groove along the inferior to internal border marks the path of nerves and of blood. So here we can see our junction with the costal cartilage, this rib here, this being the shaft, costal groove in here, the angle, tubercle, neck, head, crest, superior, and the inferior articular facets for the vertebral bodies, for the spine to be attached there, right? The posterior side is kind of more the anterior, right? And then look at this costal facet here, or this here, the thoracic vertebrae here. The costal demifacet for rib 6 would be attached right there. Costal facet here, costal facet for rib 6 here, right? And the tubercle attaches right there, and the neck for that rib, and the head here is rib 6. The same thing on the opposing side, right? And same view, but now seeing it looking at more or less of an animation, more toward the look of what a typical spine would look like. Very similar, of course, to the animation there. Shaft through rib 9, here's their angle, there's the neck, and there's the attachment point there with that head here between T8, T9, right there with that rib. And of course, the tubercle here of the rib articulating with the vertebral transverse process. Okay. The rudimentary cervical rib, it may form 7th cervical vertebrae. It may compress the artery and nerves extending upward toward the upper limb. It can produce tingling or pain. Some individuals lack a pair of 12th ribs. There are the diffused ribs here, bifid ribs, splits in 2 portions where it reaches the sternum. You should be able to answer them with the rib cage here and that sternal structures, whatnot here. What sternal structures form the sternal angle and what is its clinical significance, and where specifically do the head and the tubercle of a rib each articulate. And that is section 8.5 into 8.6. We'll come back with 8.7, talking about upper and lower limbs shortly.